All right, so hi everyone. Tonight I'm joined with Jackson and Ben from Solushin. So tonight what we'll be talking about is medial tibial stress syndrome and the Australian design solution for its potential use in a load management plan for your patients. So guys, thank you for joining me tonight. How are we?
Thanks for having me.
Awesome. Really good.
Now that you're let out of the house.
Yeah. 100%. So good.
So Ben, you're in Sydney, aren't you, Ben?
Yeah, I'm in Sydney. I've been having the time of my life up here.
Being allowed outdoors.
Out in the sun for long periods of time, getting more freckles. No. So I've been talking to a lot of clinics down there. It sounded horrible. So
yeah, I'd take my hat off to anyone that's managed to survive it in Melbourne. I would have gone insane.
Yep, no, we're going good. Finally allowed to get on the beers, which is what we were talking about earlier. It's been good.
Been on the beers the whole time.
Yeah.
Outside,
yeah.
Outside
at a venue.
With other people. Yeah.
Not at home with your birds.
Yeah, 100%.
Okay, so basically with the Kinetic Therapies platform, we do have a really broad range of people that are following us here. So there are a lot of sort of podiatrists and even other health professionals and just the general public that don't really have a good understanding of what we talk or what we're referring to when we talk about shin splints or medial tibial stress syndrome. So first up, I'll just throw it to Jackson. So you've been experiencing it off and on for years and very well researched in the area. So can you give us a little bit of a concise rundown of MTSS?
Yeah, so shin splints is a very frustrating injury, which Ben understands as well, and it's essentially an overuse injury. So shin splints is the umbrella term, which describes all sorts of exertional pain that you get when you're running or doing your sport down around the shin area. But and there's lots of different conditions that fall under that umbrella. Such as your stress fractures and your compartment syndromes as well, which are a little bit more serious. But the medial tibial stress syndrome is sort of just that general dull aching around the shins, the lower half of the shins, whether it's on the inside or the outside. But it's a really frustrating injury. It's generally a bit of an overuse injury, sort of too much too soon. There's a bit of the literature is sort of unclear as to whether it's more bony or fascial / muscular involvement around in that area. It's more leaning towards bone, but as we're going to talk about soon with the solution, there's a bit more, there's potentially a bit more fascial and muscular stuff involved than the literature says at the moment. So yeah, it's a really interesting topic and something that I've suffered with myself personally as an athlete, and only just recently, now that I'm learning a bit more, getting to the bottom of it myself. So I like helping people with that as well as a clinician, and yeah, it's a good topic to discuss.
Yeah, and Ben, you've experienced medial tibial stress syndrome as well, or is it just general sports injuries that you've kind of been playing off and on?
Well, I was a swimmer, so my worst injuries were my shoulders, but yeah. I do remember we had this, the first time I ever had MTSS, I didn't know what was going on as a swimmer. I had no idea when my legs were sore. I just couldn't respond well to that. So we were doing a boot camp running along the beach. Our coach was making us fill up these barrels, like oil barrels full of sand, and we had to run up and down this, a couple of miles beach. And it was just then and there that I started getting it. And then I didn't shake them for years, pretty much every time I cross-trained for running to stay off my shoulders as a butterflyer. My shins would just flare straight back up, and then I'd get put on the bike, stationary bike, which was horrible because it's stationary, there's no scenery. And then as it progressed and I got to ride in hot rooms and altitude rooms, I grew to dislike it more and more. But it was never my colleague, Will, who's now the unregistered orthopedic registrar, so just a young guy. He had it every year, I think, from 14 to 22 as a runner, and just couldn't work it out. So for me, it just meant other training options. For him, it meant really affecting his season, every single year. So a big deal for a lot of people.
Yep. And so between the two of you, and even from myself, like I have experienced it as well. And I know mine was 100% a training error. It was, I discovered running during a stressful time of my life. So I decided that straight off the bat, I'd run for probably half an hour every day. And that brought me unstuck after about a month.
Yeah.
But I did follow the pretty typical pain pattern that's described, where it's a bit cranky when you first start running, and then it'll settle down a little bit. And then gradually it just got to the point that as soon as I'd take 1 or 2 steps in a run, it was just killing me. I was in the gutter crying.
Yeah.
So what other
nasty.
therapies have you guys used when you've both had MTSS? So we'll go Ben first.
Oh, so basically just rest for me. That's all I got told. I got to stay off them. I got some massages. I didn't find in terms of, massaging and then maintaining like a high running load, I didn't find it too effective. I found really good short-term relief. But I honestly, mimicking literature for me was just, if I didn't run and I backed off, that was my best bet. But, I just, for various reasons, it sucked. I know Will he changed up his shoes, tried orthotics. I know he got some pretty good relief from memory. I think he got some pretty good relief from orthotics, but he could never kind of shake them. And it, as Jackson would probably attest to, it's just this whole, you end up realizing what causes it, but you can't help yourself, training hard and, loading up too quick, particularly at like a younger competitive age.
Yeah, definitely. I agree. So I was told, so I got orthotics when I first got shin splints, and they were really, really helpful. So the podiatrist that helped me did a good job. I had orthotics, and they helped reduce my load and help with my shin pain for like the rest of that season, and probably into the next season as well. But then after that, as I went on, they sort of just, I could never shake them like you said. So they were always sort of there, just grumbling around in the background. And I'd have flare ups, and then go through periods where, oh shit, it's flared up. I need to rest again. And then obviously by resting for too long, you become deconditioned to running. So then you try and go back to running, and it flares up again. So you just get into this never ending sort of injury cycle. And it's a lot of it is, I've found, has been psychological as well. Not in the fact that it's all in my head, but being told that you need to rest is sometimes not the answer, because sometimes when you've had that shin pain, especially for a long period of time, it becomes like a chronic sort of hypersensitivity in that area. So any sort of loading on the shins is going to flare up that area, when you actually need to keep pushing through that a little bit to get through that initial loading sort of tolerance phase, and build up your load tolerance, and so you can start to get into longer runs. But if you've been told that you need to rest and you can't run on it if it's sore, and that it's sore, that's something wrong and you need to back off. If you've been told that as an athlete, then you get into this mental loop of, oh, it's sore, I can't run. And then you just become more and more chronically deconditioned. And I think the research actually shows that the longer that MTSS goes on, the harder it is to recover from.
And that's,
I can relate to that with a variety of injuries. Yeah.
Yeah. And even other tendinopathies and everything like that, the longer they're there, the longer it takes to break the cycle, because you've got the psychological components, the movement habits, the fear avoidance, everything flaring into that. So what we'll do is, we've covered a little bit about what MTSS is. So like we said, there's no sort of definite consensus as far as what it is. It may be a combination of the tendinopathy, periostitis, periosteal remodeling responses, and the tibial stress reaction. So we've kind of covered that. All of us have experienced it, a lot of the time training errors. So Ben, can you give us a little bit of a rundown on what the Solushin actually is? Yeah,
so I do have one here that I can show just on the camera, but the whole philosophy was everyone on the team was an athlete to some level. So there's Will, who was a runner, I was a swimmer, and Rosa, who's a product designer, was also a gymnast. And we actually didn't come together just for shin splints. We came together with this notion of, so mixed backgrounds, all wanting to do medical product design. And we all just hated the fact that we got told to rest for so many injuries. Like, rest, that's it. That's the gold standard. Doing your strengthening exercises, sometimes, for me, I know with my shoulders, I was prehabbing up to an hour before every session for years. And then I still required shoulder surgeries, and things like that. So I was doing everything I could. Will did everything he could. Rosa did everything she could. And it basically just got to a point where, as an athlete, you kind of get over it. So we came together, decided we wanted to make something for an injury that was affecting a lot of athletes. Will put his hand up straight away and said, let's do something for shin splints. And we went, all right, so how can we reduce that time at rest, kind of give the athletes a safety net. So when they get the injury, if they're at a point where they can't deload, so maybe the end of the season, there's something for pain management there to kind of help them get through. But if they can deload and they can follow the correct processes, it's not such a heavy mental burden. So, we can turn something, from, like years, or, for some athletes, it takes 6 months of consistent load management. How can we make that become 1 month? Can we reduce it even more? And we're very early days at the moment. So, but, the whole hypothesis of the device and the way it works, got a fresh one here. I don't know how good we can show it on the camera. So nice and blue, so it sticks out like a sore thumb on a leg. But the mode of action, compress the periostitis along the distal third of the posterior medial tibial border. So, often very tender at palpation for a lot of patients, but then also in terms of the muscle dysfunction going on, we chose the soleus for reasons we can get into later. We just target the soleus origins or muscular tendinous junctions, these little compression nodes, to effectively, the goal is to lengthen the soleus muscle, so reduce tension in the soleus, and use it as an adjunct. So our joke in the office, or the joke amongst us all is, load management's the hot dog. I've heard, I think Jackson say load management is king. We call it the hot dog. There's a variety of condiments. There's your ketchup, which is what we call that, the strengthening exercises. The relish might be the orthotics or the shoes, and then wear the mustard. So coming at it for a whole kind of holistic treatment plan.
Okay, so with that, do you find that there's sort of a particular type or like cohort of people that the solution's quite beneficial for, or is it sort of something that can be applied to almost everyone and anyone?
No, I wouldn't say that. So it is early days. So because we're targeting, for example, releasing the soleus muscle, I would initially have thought, well, maybe if someone presents and they've got a good knee to wall, good dorsiflexion, maybe they're not going to get the same outcomes, considering it's such a big part of the mode of action. But now we keep seeing athletes who have good dorsiflexion getting results as well. But I think the best measure, the best thing to follow at the moment is, if we were to group across the 4 stages of MTSS, stage 4 likely being a stress fracture. I think that's too far gone, and more elaborate treatment methods should be taken. I think if, stage 3 or stage 1, when they're only a little bit sore when they're running, I believe, all the way to stage 3 that, they're very sore when they're running, but not for the rest of the day. I do think that's kind of the cohort you can use it for. I think all you have to do then as the podiatrist is make sure you're taking in the other precautionary measures. So this isn't something that we have evidence that says will stop the progression to a full stress fracture, a full stress response. So I wouldn't bang it on them and give them the thumbs up if they're at stage 3 and wish them well. I would only use it as one part.
It's yeah, I found that there's a certain type of patient that basically you'd want to use it for.
Yeah.
And yeah, that's exactly right. So someone, if they're sort of heading into actual stress fracture territory, it's probably contraindicated. Have you used it with any patients, Jackson, or are you just using it personally?
I haven't had the chance as yet to prescribe it to anyone, but I've been using it personally for a couple of months now. And where I've found it most useful is after my longer runs. So it would have been heaps useful before when I actually had really flary shins. But now that I've sort of gotten past that with good load management and strengthening, then what I'm doing now, some longer runs. So I'm really trying to push my capacity, push my running loads up and up. So when I do my longer runs, say an hour plus, I start to get a little bit achy, a little bit grumbly just around the lower portion of the leg. But it's not an issue. Like, it's not a flare up. It's just the response to the long run. Then I get home and I chuck the solution on, and generally it feels pretty good after a couple of hours of wearing it. It feels a little bit looser, feels a little bit less achy, just generally makes it feel better. And I think that's I think that's a good thing. It really helps, I guess, managing that load a little bit, because sometimes after I go for a longer run, and then you may be limping around a little bit afterwards, or in general, and that the solution sort of helps with that, and definitely recovery. Like, if you want to run again the next day, I've found that when I use the solution, it definitely helps with that. It makes those that second subsequent run a lot easier.
Nice. And so that kind of leads us into, so Ben, I know like before we went live, we were sort of talking about there's kind of two different cohorts of people. Some people use it as a pre-activity intervention, and other people use it as a recovery one. Does it really matter? And like, what are you guys finding with it? Is it more of a recovery tool, or can it be used as a pre-activity intervention? Like,
well, if Will on the team had his way, everyone would wear it before and after. But what we're finding is, I think it's, so we did a program where we we did this kind of in the design process, spoke to a lot of runners, spoke to a lot of physios, podiatrists, sports physicians, and we kind of worked out, well, we knew it couldn't be worn during, as even though you don't want to wear it during. We didn't want to design something for during, because no one wanted to wear it during activity. But there wasn't really, at the start, like early days, I would have said, all right, the people who wear it before, who said they would want to wear something before training as a prehab tool, would be, your, more methodical kind of, prehabers, like, physios, podiatrists. You see it all the time, like the athletes who are the ones who show up early, put things in place before training. But then you've also got the gritty ones who just want to hurt and deal with it after training, which sounds like Jackson and his long runs at the moment. He just puts himself through them, and they tend to wear it after. And what we found in the long term, we haven't seen any difference. There's no difference yet. The RCT, it had the limitation, of the size of the cohort. We couldn't see a distinction there in the long term, but now it's on the market. And we're keeping up all just the post-market surveillance. As a medical device, we're not seeing any difference either. All we find is if you tell them before and after, they pick one. They pick one, whichever suits them. And I think for the podiatrists out there, we're not seeing any difference yet. So I think giving the patient the opportunity to choose at the moment, before or after, kind of allows them to see where it fits best in their routine.
And I guess that kind of will stand to reason a little bit, because like with many interventions, especially one as new as this, like, we're not 100% sure on what the actual mechanism of action is. And it is very similar to that with a lot of the other interventions that we do anyway in the clinic, and even some exercise therapies. And a lot of the time it's what feels good for the person. Do they feel a benefit when it's introduced in this time of the day or before this activity or some other time? Like, we don't know, so we can just give them the option, and they will have an idea on how they're responding. And this will kind of steer into, and it's a bit of a how deep can we go down the rabbit hole, like you said earlier, do we actually have much of an idea on the whole theory and mechanism of action of how this works?
Well, we've got the, so basically the RCT's key measures were the return to full load training, and then we used, I can't remember the author's first name, Winter et al. Had a MTSS patient reported outcome measure survey. So we use that to gauge pain severity.
Yep.
So it is a patient reported outcome, so how much pain they're feeling. We've got those measures. We've got an ankle ROM study, so we're seeing an improvement on their knee to walls. It was 21% after an hour of wear. So we know those things, but in the middle, right? So we can only hypothesize, unless, I think that releasing calf tension, like we were talking about before the call, we can see the outcome in the patients, but as soon as we start to go, right, well, why does applying counter traction or to those areas definitively result in this release in tension? It just gets it's a very deep rabbit hole that we can go down. I think, again, back to Will, I'm sure he would love to cut open some calves and do some biopsies, work it all out. Jackson, if you want to be the first one to put your hand up, you can you can do so. Give you a couple of beers. That's actually as well. I come from a biomedical engineering background, and as an athlete, and what I'm very open about with everyone I talk to who's in clinic is I've got this research background, I've got this athletic perspective. So ask me questions, I'll ask you questions, help me continue to develop this perspective in clinic. So what do you think's happening, and where do you see this best fitting in clinic as well? So that'd be one of my questions for both you two, if you had any ideas, or if you wanted to go into the rabbit hole about that calf tension stuff. Fire away.
Love a rabbit hole. So I don't know why it would be working, but I think it could potentially fall into some of the categories like massage, like just that sort of pressure, because we've got like the what are they, the Pacinian corpuscles, the Merkel's discs, all of those mechanoreceptors that are located within tissue, and we know that a few of them, they respond to pressure and light touch, and potentially whether or not it's the application of pressure to those areas that triggers that change in the nervous system, where we may get a little bit of downregulation of the muscle tension. And if that's like, to me, that's potentially where I could see it working, because it's the same as like I know in the RCT, they've mentioned that there's like the whole trigger point theory and everything like that. And again, trigger points, that's its own dumpster fire of whatever. Everyone's got their opinion on it, but essentially we don't know if they exist, but we do know in some instances that the application of pressure or stimulation to those areas can result in short-term changes in passive muscle tension. So whether or not it's just the stimulation of those mechanoreceptors that cause that sensation or that result. And that might be why, because I know you mentioned that there's like that, you did the ankle range of movement an hour after. Do we know how long that benefit maintains? Like, is it like, does it start to wear off like it does with massage therapy and shoulder mobilizations?
Yeah, so regarding that, we've only done very small pilot studies. We're currently doing, so we've got the Edinburgh rugby team, we've got a couple of players doing some clinical, so they're wearing it and they're doing a bit of clinical testing for us over in Edinburgh. But the goal there is, they've got a lot of high risk players for a variety of injuries, all these players get their knee to walls done every single day throughout pre-season and through the season. So what we're hoping to do is use the solution then to see those long-term kind of outcomes and see what happens. We've done the pilot studies, dead set on a couple of us, no exaggeration, where it was just, we wonder what it is. As part of my thesis at uni, my honours thesis as well, was like, well, let's see what happens over 10 days. And I did have, on the 10th day, there was a 23% improvement, but, before I had worn it compared to the other days. But honestly, you know, that's a terrible kind of clinical study. So
most of them are.
So, you know, that's just what got me through my undergrad. Part of what got me through my undergrad. So
plenty of journals and publishers. Jackson, do you have any concepts?
And
I've just thrown you in.
Yeah, no, so that massage sort of mechanism is a pretty good idea. That's probably the most likely one as far as influencing the nervous system in general. I think that's probably the most likely mechanism, but potentially, some like if that traction, if there's traction on the lining of like the periosteum, if the fascia and that is pulling on the periosteum, perhaps the compression in that area helps to take some of that tension away. I don't know. Ben would have to talk more about that.
One of the theories which I was talking about before the call was, you know, because I'm just trying to, like, this is something we're trying to understand the why, you know, as best as we can. You know, and this is, as we said, the big rabbit hole. I've seen the theory that, well, if you're applying counter traction down, you're stretching those muscle fibers where all the high tension is, and that allows the sarcomeres to resume their resting length, apparently, you know, things like that. But, you know, we made our assumption basis, as you saw in that manuscript for the RCT, you know, on mechanotherapy offering good acute symptomatic relief, and then also causing that release in tension in those muscles. So we just took the outcomes other people had seen and we're like, how can we apply that to the soleus? And that's what we went with. The why is a question we would love to figure out in the future, but I think that's across the whole community as well, not just for our product. For a lot of people, they're looking for that why.
Oh, with most interventions, isn't it? Even with exercise therapy. So, and then that would kind of lead us into, so the solution itself isn't, like, it's a medical device, but it wouldn't be a treatment in isolation. No?
Oh, look, the best outcomes are going to come from, we even showed in the RCT, the patients who had undergone, you know, the load management programs prior and had experience in other treatment modalities. Like, everything about our RCT was to show, you know, we were athletes. We're not going to expect other athletes to only give one thing a go, you know, when they're injured. That's just silly. You know, no athlete would want to do that. They're going to want to be hit with everything that's going to help them. So we knew that it was about being an adjunct. We know the best outcomes are from using it in conjunction to load management. On top of that, if you've got a patient where you identify a biomechanical fault that should be addressed, how you best think to address it, do it. I personally think you should also be doing strengthening exercises, you know, hands down. You know, if you've got some dysfunction and weakness, you know, address it. You know, quite a simple thing for me to say. That's just my personal belief as well as what we see in the research. But then on the other end, we've had patients who they couldn't do all these interventions, and they've used it as pain management, but then over time they've returned to running anyway without, you know, any other intervention. It's not what we recommended, and there hasn't been, you know, enough for us to, you know, say go for it. But I think that for us just raises another question behind what's actually occurring in the injury, because that's challenging our beliefs that, you know, load management is the hot dog kind of thing in this as well. So, or load management is king. Yeah.
Well, I guess, like, in that person's, like, scenario, it would kind of depend on their contributing factors. So if load management was primarily their problem and they didn't have a huge requirement for strengthening. So, like, for people that don't really know, there's a couple of the theories, like your flexor hallucis longus, the soleus, and just general calf strength. sometimes they sort of theorize that having decent calf strength and muscle cross-sectional area can help counter some of the bending moments that happen on the tibia during weight bearing.
Yeah.
So for some people, if they do need to build up that muscle strength and cross-sectional area to counter that tibial bending moment, then strengthening may be a real big cornerstone of their treatment. But on the other hand, in that person's case, they may have had adequate muscle size. They just hadn't had exposure to that specific load, and that may have been all the load management that they needed. But essentially, that's where it all comes back to your clinical assessment and history taking, doesn't it?
Mm-hmm. I think, I don't know him very well at all, but I saw at the SMA conference last year, there was a presentation. It was sufferers versus non-sufferers under MRI imaging. I think it was Joshua Maddock from the University of Wollongong. And he also did see that for the MTSS sufferers, you know, there was, I think, and, you know, don't quote me on this, but I believe it was about there being lower bone and soft tissue density along that distal third of the posterior medial tibial border in sufferers versus non-sufferers as well. You know, and my interpretation of that when I saw it was basically, you know, biomedical engineering didn't do anatomy and physiology as much as podiatry and physiotherapy, but I learned about Wolff's law, and that was kind of where that played in when I connected it to that, you know, the overuse injury and not following the correct load management. Well, your body hasn't been able to adapt to the load it's currently under. It's unable to handle those stresses, the bending moments. You know, if you get a small stick and start pounding it vertically into the ground, you know, the thinner twigs start to crack and bend very easy, you know, whereas the thicker twigs, more dense, you know, they can withstand those bending moments and that are generated from that force as well. So, you know, I've heard a lot of good things, but, you know, I think understanding that it's a syndrome and there's a lot of causes is kind of, even though it makes it an even more complex and deeper rabbit hole, I think that's step one to kind of recognizing the difficulty of treating the injury sometimes.
Like most lower extremity pathology, there's no hard and fast rule. And yeah, with that whole periosteal response that he spoke about, and like this sort of goes back to, you can apply it to pretty much any musculoskeletal pathology that physios and podiatrists treat. It's the same with bone loading, tendon loading. Like after you've had an exposure to load, you do have that period of time afterwards where the structure's a little bit weaker because you're having, in the case of bones, you're having the osteoclast activity, and it sort of basically it's weaker for that short period of time until you actually get the osteoblast laydown of the new bony tissue. Again, this will tie back into training errors. So if you've got someone who they've just gone too hard too soon, training error, guilty, that can potentially be why they've got that sort of softening that they see in the periosteal edema. So again, it's comes back to the load management, and then I'd say the solution's probably more of a, I'd say symptom manager, but also how I would probably best describe it if I'm sort of talking about how I've used it in the clinic with patients or clients is it helps with the treatment window. So essentially any therapeutic intervention that we do, whether even if we don't know exactly why it's doing it, so manual therapy, Solushin, manual joint adjustments, whatever we want to do, dry needling, we get a short-term response, whether or not it's increased range of movement, decreased pain. And with that treatment window, one, it psychologically helps people. Two, it can dampen down pain responses, but then it can make the body a little bit more responsive to when we do introduce that load. So it just makes that sort of window of opportunity for the body to adapt positively that little bit bigger.
Yeah.
So would you agree with that, Jackson?
Yeah, definitely. Definitely more after, definitely I've seen the benefits like after running. So I guess that makes sense. So, yeah, no, I would agree with that. And yeah, it definitely in conjunction with other things like, you know, if you if you're going to go delve into, you know, dry needling and massage and that sort of thing, then, you know, chucking the Solushin on top of that, it's not going to hurt either. But yeah, it all comes down to the load management and the strength as well. Strengthening, with the muscle mass and the helping with the bending moments and that sort of thing. That's all relevant. And also, I don't know if there's been much research on the like stiffness, so stiffness of the ankle and the hips and trunk, and just our ability to prevent our body from collapsing when we're running. So vertical stiffness in general. I don't know. I haven't read any research on that.
I don't know about in specific relation to MTSS.
Yeah.
I know it's sort of implicate, like especially like patellofemoral. I know that's sort of thrown in there a bit. Ben, do you know of anything as far as the vertical loading and impact forces with MTSS?
No, I do not. I'm sure that is a question. Will be watching this. He'll shoot me some answers that I can forward on to you, no doubt.
It's definitely something that I've been working on a lot myself, is my own stiffness, and then with the athletes I've been working with, just their vertical stiffness and through the trunk and the hips and the ankles as well upon foot strike. That's what we've been doing a lot of work on as far as MTSS management at the moment, and it's been I guess we've been making progress.
And is that trying to increase the stiffness?
Yeah, definitely. Yeah, particularly for single-sided people are getting like shin pain more so on one side of their body more than the other. I've found that there is like a sort of for want of a much better word, a collapse onto one side of their body when they're running through their running gait. And when we're doing particular running technique drills, there is a deficiency overall on one side compared to the other. So, and vertical stiffness comes into that. So we've been, doing a lot of training, retraining stiffness, a lot of plyometric stuff, skipping, hopping, that sort of stuff, and loading, skipping and hopping up, like adding extra load above head with weight and that sort of thing. That's coming a lot into my management plans at the moment.
Yeah. So essentially the management plans are trying to, when we say increase stiffness, is decrease the amount of deformation that occurs, whether or not it's like collapsing through the joints or extension of the tendons. And so it's basically the body storing and releasing energy more efficiently. That'd be what you're referring to, just for the
and
understand it.
Yeah, and whether or not reduced capacity to do that is implicated in MTSS. There's no research for that, not that I'm aware of. But when you look at the vertical impact forces and the bending of the tibia, like with the twigs and the sticks analogy Ben used before, that's where my mind goes with that.
Cool. Now, Ben, I know it is a compression device with the Solushin. So are there any issues that may arise with it being sort of too tight or too occlusive if someone's using it?
So regarding occlusion, we did do a safety study, and I think the highest we could crank it up was about 70 milligrams mercury, and we weren't getting occlusion. That was all we had, Will and a couple of the other MDs did all the verification on that. But I do think, there's a variety of, things that I wouldn't use it for, because of the compression. So, compartment syndrome is a big, obvious one for me. And now I say that, but then we've had some NRL players and their physios use it for exertional compartment syndrome of the tibialis anterior, against my recommendations, and they were happy with the results. But chronic exertional compartment syndrome was pretty much on that list of, I wouldn't use it if the patient is presenting with that. Popliteal artery syndrome, entrapment syndrome, and then pretty much any patients with any kind of peripheral vascular disease, particularly now in the early days of this being a medical device on the market, it's not just for us a our little safety net as a business to kind of cover our asses. It's basically, we don't have the evidence to say it is safe, so don't use it there. You know, the patient cohort, you know, again in the clinical trial was relatively young, you know, so we don't even recommend in clinics that if you have someone who's 45 and over, you know, we don't have anything in place to say they're going to get the same kind of clinical outcomes as confidently as well. So, you know, early days, we'll work all that stuff out. But as a compression garment, I think there's a few things not to use it for. But regarding arterial occlusion, which is the first question I get asked, you know, no, we haven't seen any issues there at all.
Yep, nice. So, and I think that's really good to know, for because it's one thing like knowing kind of what we can use something for, but
Yeah.
I think medico-legally having an idea of what we shouldn't use it for, that's also a good thing. So if we were going to basically wrap it up, so we've got the Solushin can be quite effective, but we're still not 100% sure on how and why. For people that have medial tibial stress syndrome or shin pain, that is largely related to mostly tightness of the soleus and trying to increase that sort of dorsiflexion range of movement and decrease the traction tension. Anything else that you guys would like to add?
No, not really. I think that's pretty good summary. And yeah, I've used it myself, and it certainly helps with the just general soreness and fatigue feeling after my longer runs. But yeah, definitely a good adjunct. And in the past, I'm not really a big fan of adjunct therapies due to the clinician sort of over reliance on them in general, and then the patient over reliance on us as clinicians. So I really like to be like proactive about stuff. So when I got the the Solushin and I started using it as an adjunct, I was pleasantly sort of surprised that I sort of realized that it was actually quite helpful. So yeah,
I think one of the other really good short-term outcomes we're seeing as well. So if you've got a patient who's very tender at palpation at the arm, you know, like that distal third of the posteromedial border, so suspected of periostitis, that rod offers very quick pain relief. As in, you know, we've had patients put it on and it's immediate for them, particularly if they've got it severe and they're kind of hobbling around a little bit, trying to avoid aggravating it anymore. So there is that really good short-term outcome there. But yeah, like, you know, the RCT we saw, you know, it was just over 5 times quicker return to full load. So using it alongside full load for us is the go-to. We know we get the best outcomes doing that, but then we also know it helps significantly with full load, returning to full load as well. But that's the thing, just like Jackson was saying, like, we don't also want patients going off and, you know, they get those short-term pain relief outcomes and they think they're good to go. They haven't been educated properly on, you know, the other correct methods of treating. So the load management, if they, you know, need to address those biomechanical faults or weaknesses in their calves, you know, trunk stiffness, like we heard. So making sure the education's in place when you give them the device, to not just rely on it. You know, the best outcomes are going to be, you know, having that full holistic approach.
100%. Yeah, and like, I must admit, with me, who is probably more erring on the side of, similar to Jackson, not a huge fan of lots of adjunct therapies.
Yeah,
I do use it. Like, my left leg always blows out, usually in a training error. But I do really find that it is easier for me to back it up if I'm having a couple of long runs back to back. And like, I've always had issues with the soleus, like both legs. I was a toe walker when I was a kid. It's always been a problem for me. So yeah, for me, I do find that I use it more as the recovery tool, not the preloading. And does it replace other things? Like, I could probably maybe foam roll, but I'm not compliant with that. So I do find, for me, range of movement and recovery wise, it does help with me. I have tried it with a couple of other clients and they haven't found it's done anything. And then there's been others that I've used it for and it's netballers, runners, soccer player. And yeah, so I'd say out of it's probably about 6 or 7 people, I'd say more than half of them found that it was quite beneficial.
Awesome.
And pretty much with all of the prescription that I did with it, it was in a recovery sense. I wasn't going to do it. So that's just my sort of limited exposure with it. But I think it's great. And yeah, if people can get in touch with you, and I'm pretty sure, is Brigitte a supplier?
Yep. So we're distributed by Brigitte now. We're also distributed by a couple of physio suppliers and DBS Medical, but I think Brigitte are going full force into the podiatry community with the device. So if you want to order it, they're definitely, I believe, one of the ways to go. Them and DBS, whoever's the best for you in the podiatry community. Alpha Sport for physiotherapists, and 8 Medical also distribute it. But any questions, just reach out to me. I'd love to chat to pretty much anyone about it. There's a lot of good things and cool things we've seen across a lot of professional teams, all the way down to amateur athletes. So yeah, I'm basically the merchandiser running around putting it on everyone's legs at the moment.
You're doing a good job.
Thank you.
All right, so we might wrap that up for tonight. Thank you so much for joining us, Ben. It's a really good product, and I love hearing your thoughts on it. And Jackson, as always, it's good to catch up.
For sure. In person soon, hopefully.
Yes, many beers.
No, thank you so much for having me on. I appreciate it.
It's been great. We'll talk to you soon, Ben.
Right, thank you.
Yeah. You're back then.
Yeah, I came back. As I signed off, I heard you guys were continuing, so I just came to
I didn't
thanks afterwards.
tell you, because I could hit stop the stream, so it stops the streaming, but it keeps us going.
Yeah, classic. Yeah,
but I should have typed it in there. Sorry. Thank you for that. That was really good.
So, no, cool. But your stiffness stuff, Jackson, I wrote that down. I'm going to check that out more because it's. Yeah, always trying to work. Yeah, that's a new one for me, hearing that angle.
I wanted to launch into it, but I wasn't sure that I could articulate it well enough for how long the day's been. And it's sort of, how we were talking about whether or not it's more beneficial first thing in the morning, or not first thing in the morning, but before activity or after activity. Yeah. And then it kind of steers back to like musculoskeletal pathologies and like stiffness and compliance. So like with a lot of people, if they're too compliant and we want to increase their stiffness, then perhaps using it before loading isn't a good idea, because it's that whole thing like doing the static stretching and massage before you're actually doing an activity where you need stiffness for that energy return.
Yeah.
It could potentially have an inhibitory action and decrease performance.
Yeah.
But then on the other end of it, if you've got someone that's too stiff, so they're not storing enough energy to release, then that can potentially be something that you may want to use before they're actually loading to give them that little bit of compliance so they can store and release energy a little bit better. So that's one thing that I was thinking, but I wasn't sure how I could articulate that.
Yeah.
But, so that's a potential thing. And that it's like, not so much with the Achilles tendon or the tib post, but it's like how with eccentric exercises and stretching for tendon pathologies, like the isometrics, it has a pretty decent body of literature for patellofemoral or patella tendons. But it's a little bit of a mixed bag with the Achilles. And then when you kind of look at how the two tendons are meant to function, the Achilles is meant to store and release a lot more energy. So a lot of the time you don't want it to be too compliant, whereas the patella tendon, it's shorter and we want it to be quite stiff. And then some of the problems occur when it's too stiff, if that makes sense. So,
well, I was just going to say, we recommend you don't use it on days you compete if you're a pre-training wearer. And that's just, it wasn't a lot of research into that decision. That was just my whole as a sprinter, like my whole life, I was told, yeah, not to stretch prior to races and things like that, you know, not to roll out, you know, things like that, because, you know, they wanted us to store, or they, you know, store the power, which was basically what they said, which is basically just not loosen up too much. And Will had the same thing as a 400 meter runner. So, you know, and as well as just superstitions, you know, as a performer, you don't touch me on the days that I need a race. Yeah.
Yeah. Gotta wear my magic undies.
Yeah.
So that'd be interesting. So that was just my random thought process that I wasn't sure if I could articulate it well or not. Probably
no,
not.
that's good. That's good. That's you should articulate that. You should do it in like a blog or something. That was interesting. Yeah, and I agree that, it makes sense. So,
well, we could, because this is still actually recording. We're just not streaming. So we could throw it on as a little bit of an afterthought ponder. But that's sort of my 2 cents worth with it. So essentially, figuring out if it's someone, like when to use, if it's more stiffness or compliance that we're after, that can potentially indicate when you would want to use it. And then the other thing, I've lost shit. What was the other thing we were talking about? Fuck, it's gone. Anyway, so that's one of them.
Awesome.
I can't remember what the other thing was. It's gone. I don't know.
Yeah, with the tights, you know, having tight soleus or poor knee to walls is a kind of like indicator that it might be better. That's what we said at the start, and then there was just a couple of patients who didn't have that and they still banged it on, and then they were really happy, and then we were just like, as a team, we were like, well, why the hell did that happen? Like, pretty much, you know. So, you know, whenever we haven't had many patients, or at least in terms of feedback, haven't had, you know, positive results. So it's actually good to hear from you. You've like, all right, well, these patients didn't get the results. So then we can go why, and then we can start refining that kind of when to prescribe it and when to use it, because, you know, right now it's really based on when not to use it kind of thing. So, which seems to be as well, I don't know what your thoughts are with MTSS. I was reading Tom Goom and then Simon Barthold stuff, and it was like, it's not about for them diagnosing MTSS as like the first thing you diagnose. It's about ruling out everything else and then going, all right, this is what's left. It's not a stress fracture. It's not this. It's not that.
So it's now the fibromyalgia of the lower leg.
Yeah.
Which sucks.
I don't think it was Tom Goom. I think it was in Simon Barthold's ebook on it. So, yeah.
And I still can't think of that other random thing I was going to say. So we were talking about stiffness and compliance, and then, no, I'm sorry. The day has just, my brain's just gone, nah, I'm out. That's all I got. When I think of it, I will email you guys. There were 2 brainwaves I had.